Hi, everyone. My name is Alex Chan. I am currently the president-elect for Multinational Association of Supportive Care in Cancer, or MASS in short. I'm also a professor and chair in clinical pharmacy at University of California, Irvine in the United States. Thank you, OncoAlert, for inviting me to give this talk to provide an update on cancer supportive care. This is the outline for the talk. I'll give a very quick introduction to our organization, MASCC, followed by the guidelines that are recently published by our organization. And then I'll conclude with Q&A as well. So, MASCC has been around for a long time. We are an international interdisciplinary organization that's dedicated to the practice, education, and research of supportive care in cancer. Our motto, as you can see in the bottom here, is every patient with cancer needs supportive care. And obviously, good quality cancer care must come with adequate supportive care. We have a very large global organization that encompass all aspects of care, and you can see the breakdown of our professionals that's involved in our organization. Please look at our website if you haven't had a chance to. We have a lot of guidelines, resources that are useful in the area of cancer supportive care. These are our study groups. So when you join MASS as a member, you automatically become a member of three of these study groups. And a lot of times, in fact, our members are interested in more than three, but we restrict to three. But more importantly, you can see these are focused on very crude or very important areas and domains of cancer supportive care, ranging from toxicities to very contemporary issues. So I invite you once again to join our organization and find out more how you can contribute to these different areas of cancer supportive care. And of course, for our organization, very importantly, we do have many clinical practice guidelines that we collaborate with many organizations around the world to manage a lot of the supportive care issues. So you'll hear today some of the guidelines that we're putting out. And in my other colleagues' talk, Dr. Hirotoshi, he's going to talk about some of the work that's going on related to antiemetics. So that's going to be a separate talk. So I'm going to focus on a few of the guidelines that we have put out, which I think it is important as an update in the area of cancer supportive care. So the first guideline that I want to talk about is this guideline that we jointly put out with ASCO that talks about survivorship care for people affected by advanced or metastatic cancer. And you can see the standard and practice guideline comes with 7 different domains, ranging from person-centered care, coordinated and integrative care, evidence-based and comprehensive care, evaluated and communicated care, accessible and equitable care, sustainable and resource care, and lastly, research and data-driven care. So the background of this guideline is that a lot of work that's being done in the area of cancer survivorship is focused on curable disease patients, but less in the area of advanced of metastatic cancer patients as well as their caregivers. And of course, in this particular group of patients, there are many different care goals as well as unique challenges. So this particular joint effort between MASS and ASCO was to develop standards for quality survivorship care for people that are affected by advanced or metastatic cancer. And of course, the guideline is not just for us healthcare professionals, but also important for many key stakeholders, policymakers, hospital health and health services administrators who play a role in terms of managing the care of these cancer survivors. So the main research question for this particular guideline is, what are the standards for quality, advanced or metastatic cancer survivorship care? So, as we have talked about, the breakdown of the guideline is really talking about different areas of care. So, first of all, person centered care. What I captured in this particular recommendation is we need to recognize people affected by advanced or metastatic cancer as individuals with agencies and partners in cancer care who are served by and participated in trusted health systems that respond to their unique needs. And I think very importantly is to highlight what exactly are these unique needs. Physical, psychosocial health systems, informational, financial, fertility, sexual, spiritual, and relationships in humane and holistic ways in collaboration with health practitioners and healthcare organizations in public, private, and non-for-profit health and related sectors. And if you look at the details or recommendations, they talk more about, what are some of the specific things that can be implemented. For instance, how do we ensure that, these cancer survivors are routinely being screened and evaluated for their needs? How do we make sure the fact that these survivors are also getting appropriate care planning? How do we ensure the fact that their goals in terms of treatment goals, life goals, etc., are shared by shared decision making? So again, this particular recommendation is very important because allowing us to holistically understand what are the needs of our advanced or metastatic cancer survivors. Coordinated integrated care is also important as well when we talk about, how to better manage these cancer survivors. And we're talking about continuity of care, coordination of care, and integrating health services across survivorship and the palliative care phases as well. So I think it is important that we think what are the approaches that we can do in team-based care to ensure that again, the care providers are being referred timely and there's a model where we're able to provide support that's needed. Evidence-based and comprehensive care is also important as well. And this particular recommendation talks about how to provide up-to-date evidence-based clinical best practice and comprehensive supportive care programs for all people who are affected by advanced or metastatic cancer that are informed and supported by ongoing professional development of healthcare professionals and educational programs that are developed and delivered to cancer survivors, caregivers, administrators, and healthcare professionals. These following recommendations look at very specific needs. For instance, how do we ensure that there's systematic sort of communications, that's multilateral communication between all healthcare professionals as well as the patients who are affected by the disease? Making sure the fact that cancer survivorship care in this group is accessible, meaning affordable, acceptable, available, and appropriate, and also equitable as well. And making sure that high quality, value based care is delivered in a cost effective yet clinically meaningful sort of manner for people affected by advanced or metastatic cancer. And lastly, with a lot of things that we do, we wanted to make sure that we provide quality care, but at the same time, also making sure that there is evidence-based research that's being done in order to ensure the fact that well-designed studies and properly funded multidisciplinary research helps to continue to drive data that helps us to improve the care of these patients. The other guideline that I thought is important that we should discuss very quickly, and this touches a lot of our work in our day-to-day cancer work is, how do we ensure that we are providing appropriate doses of opioids in our cancer patients who are needing these drugs? So MASCC-ASCO, which is American Society of Clinical Oncology, the American Academy of Hospice and Palliative Medicine, together with Hospice and Palliative Nurses Association, as well as NISCO, which is the Italian group on supportive care and oncology, came together and came up with this guideline that was just published as well on opioid conversions in adults with cancer. And I thought this is also very interesting. So one of the things that we recognize is that there's a lot of variability, and I think we see this in clinical practice as well in terms of converting opioid doses across the different drugs. And you talk to different professionals from different countries, different regions, they will provide you different information. So the guideline seeks to reduce this variability by providing recommendations regarding opioid conversions, not only in terms of like, what is a dose-to-dose conversion, but even the process on how to do that. And it builds on a recent ASCO guideline that address use of opioids for pain from cancer or cancer treatment. I do refer you to read into that. That's in the guideline itself. So essentially, it addresses three clinical questions. So what assessments are important before opioid conversion? How should opioid conversions be conducted? And what assessments are important after opioid conversion? So this talks about what are the assessment that needs to be done pre-conversion that ranges a lot of different domains, ranging from having appropriate multi-dimensional pain assessments that, again, looking at the worsening pain severity or distress or even a change in pain characteristics, to reviewing what exactly is the pain pathology and what are some of the management options. Then, of course, looking at whether or not that there are potential contraindications, and this kind of focus on things like, whether there are comorbidities, drug-drug interactions, cumulative adverse effects to identify factors that may indicate or contraindicate to specific opioid analgesics or route of administration. Then the history, which I think this is a part which I think we need to play a huge role in terms of having appropriate documentation on what are the opioids that patient had tried in the past, what exactly are the drug misuse, abuse, or addiction patterns, as well as any adverse childhood events, which I think it is important to have a very comprehensive opioid history. Evaluating for organ dysfunction is also important, understanding whether or not that patients are having hepato or renal impairment, because that may affect, again, the metabolism and excretion of the drugs. And then lastly, thinking about patients and caregivers. So assess availability of family members or friends to monitor patient closely during the first few days after opioid conversion and discuss with the patient and caregivers about the acceptability of different treatments in terms of drugs and route of administration as well. Now, in terms of the process of, again, offering opioid conversion, I think there are very useful and specific recommendations there that I think for all of us, we will find them very useful. For instance, if we have somebody who has uncontrolled pain, if pain is uncontrolled despite upward titration of the current opioid analgesic, or if the patient cannot tolerate the dose increase of the current opioid, the conversion should be offered and may be offered. And sometimes what we can do is a change in the opioid route of administration from oral to IV or sub-Q administration to enable rapid titration may be appropriate before even changing the opioids themselves. And I think that this is a very important reminder to all of us. Then, of course, you got to watch for any sort of intolerable adverse events, and talking about things like itching, nausea, that may persist despite tapering the opioid analgesics. And if symptomatic management of adverse effects is ineffective or poorly tolerated and pain is poorly controlled, then opioid conversion may be offered. Then also think about whether there are signs of opioid-induced neurotoxicities, and there are a bunch of them listed here. This is when you want to consider opioid conversion. Then opioid conversion should also think about in the setting when whether or not that there are pharmacokinetic factors that affect the absorption, metabolism, or excretion of the current opioids. And these are things like drug-drug interactions, or if patients are specifically CYP2D6 ultra-rapid metabolizers. So those are things that you want to think about whether or not that you want to convert to other opioids that may not have such issues. And lastly, whether or not that there are any availability issues or health economic constraints, then opioid conversion may be offered. So in the guidelines itself, it has a very, very nicely put together table that talks about what are some of the recommended conversion ratios. And this is done by consensus of the panel members. And I thought this is very useful to have in hand to look at how do you convert the various oral and IV agents that are used for opioid pain control. And lastly, of course, want to talk about post-conversion assessment. So, how do you assess pain to ensure the fact that, patients are responding, adverse event monitoring, whether or not that patient needs to have dose adjustments after the conversion, and more importantly, how do you engage patient and caregivers as well as additional monitoring that's needed. Like for instance, if patients are on methadone, whether or not that QTC interval should be monitored and how to be monitored. So once again, I do recommend everyone to look at these guidelines. To wrap up, I do wanted to talk about what are some of the other mass published guidelines. So we recently put out a guideline on spinal analgesia. We also have a guideline that talks about managing breast cancer related arm lymphedema, and also an oncodermatology guideline that talks about management of acute radiation dermatitis, which is also very relevant in the management of patients with cancer. So what has changed in clinical practice? Just want to summarize about our stand in terms of how to raise the quality of care for metastatic and advanced cancer patients with our very recent MASCC-ASCO survivorship standards, and also our very important guideline that talks about opioid conversion to avoid any sort of overdosing or underdosing of opioids for managing patients' pain. And that's all I have. I do welcome you to our 2026 annual meeting that's happening in June. Please join us. It's going to be a wonderful meeting. And if you cannot join this year, next year we're going to Rotterdam in Netherlands. And I do welcome you to find out more about our organization, MASC. Thank you so much. Thank you for your time. And thank you, OncoAlert, once again for inviting us to provide an update about supportive care. Thank you.